My name is Sarah Abusi, internal medicine resident at Orlando Health. Imagine a 27-year-old man with a month of fever, weight loss, progressive lymphadenopathy, neurologic abnormalities, and imaging concerning for septic emboli. At first, this looked like hemophagocytic lymphohistiocytosis, HLH. Then it looked like lymphoma. Then perhaps infective endocarditis. But the actual culprit was hiding somewhere we weren't looking hard enough, the lymph node. This is a case of invasive non-typhoidal salmonella infection presenting as a systemic inflammatory syndrome and ultimately diagnosed by broad-range 16S rRNA sequencing of lymph node tissue. The patient presented with 1 month of fever and unintentional weight loss. Because of this systemic inflammation and high H score, HLH was strongly considered. Bone marrow biopsy, however, showed no hemophagocytosis, and empiric corticosteroids were initiated. His clinical course then became more concerning. He developed encephalopathy with multifocal brain lesions concerning for septic emboli. However, transesophageal echocardiography showed no evidence of endocarditis. Meanwhile, imaging demonstrated a progressive generalized lymphadenopathy. At this point, the differential became broad: infection, malignancy, inflammatory disease, and HLH were all still on the table. An initial lymph node biopsy was non-diagnostic. This is where the case became particularly challenging. A conventional workup was not giving us an answer, and the patient continued to have progressive disease. Importantly, plasma microbial cell-free DNA testing was also negative. So we had a patient who clearly looked infected, but our blood-based molecular test was telling us otherwise. Here, the CT demonstrates extensive lymphadenopathy, including retroperitoneal involvement. The other images demonstrate pulmonary cavitary lesion, splenic lesion concerning for septic emboli, and multifocal brain lesions. Taken together, these findings suggested a disseminated infectious process. But where was the organism? The answer came when the lymph node itself was interrogated. A repeat retroperitoneal lymph node biopsy was sent for broad-range 16S rRNA sequencing, and this time the tissue identified Salmonella species. This was particularly important because plasma microbial cell-free DNA remained negative. In other words, the infection was detectable in the tissue compartment, but not in the bloodstream. The patient was subsequently treated with a prolonged course of ceftriaxone with progressive resolution of his lymphadenopathy and clinical improvement. So what does this case teach us? First, a negative blood-based molecular assay does not necessarily exclude infection. When infection is compartmentalized, particularly within deep tissue or lymph node, the organism may simply not be represented in the bloodstream at the time of testing. Second, broad-range 16S rRNA sequencing can be particularly valuable when conventional cultures and initial pathology are non-diagnostic, but clinical suspicions remains high. I think the most important lesson from this case is simple. When the blood is negative, but the disease persists, don't stop looking. Change where you look. In our patient, the diagnosis was not in the blood, it was in the lymph node. And sometimes, when conventional testing fails, the tissue has the last word. Thank you.